Good evening. Welcome everyone to the third and final webinar of Shalvata Mental Health Center in the Israeli Society for Community Mental Health, which is part of the Israeli Medical Association. Tonight is the third and final of this session of our talks, lectures about sleep, sleep disorders, and nightmares. And as usual, we are honored to have with us Dr. בארי Krakow, who's an internal medicine physician and a clinical sleep medicine specialist with vast experience and over 30 years of research and treatment. Today with me, I will be joined by two hosts, Dr. Aviv Segev, who will join us any minute now. It's a senior psychiatrist at Shalvata, and Lior Biran, the clinical psychologist, again, who works with us at Shalvata. Tonight, we will be talking about sleep quality and sleep fragmentation, and the lecture, the talk, will be recorded and uploaded to our Facebook web page and the YouTube page of the Israeli Society for Community Mental Health. I really thank Dr. Krakow for all these lectures, and he offered us to have another session in a few weeks in order to consolidate and in order for us to consult with us on our clinical experience with his techniques, which I must say personally I've already implemented in my work and psychiatric follow-ups with patients and IFT and TFI. It's working and it's really amazing. So thank you, Bağry, for your generosity, and the floor is yours.
That's great news. Thank you, Ido. So in today's, let's see, am I getting this to work? Nope. Let's see. There we go. So everything we're going to learn today applies to all three groups again. And acutely, you'll see some very specific elements. But in particular now, we're coming to this very important topic of individuals who've been troubled sleepers a long time, never gotten great results to their sleep issues, and as a consequence have often struggled with their mental health as well. So much of this today will apply to those individuals, which I hope will give you a lot of hope in terms of being able to help these individuals. Remember, we talked about what does the awakening process look like in someone experiencing a nightmare? That was the last part of our discussion on nightmares. And I think we could all agree, everybody's probably either had the experience themselves or they've had a patient describe to them that this really does sound like a panic attack. The nightmare patient wakes up fearful, gasping for air, or struggling to catch their breath, palpitations, pounding heart, racing heart, sweating. Very, very common description of the classic nightmare, which, depending upon your perspective, if you're a sleep doctor, is the identical symptom cluster that you would expect to hear from somebody who's had a sleep apnea event. So we'll get into what that may mean as we go forward. Now, another question I want to pose is, what does the sleep quality look like leading up to and just prior to this nightmare awakening? What is actually going on in the sleep? And by way of example, let's first define sleep quality. So if we have Reuven and Shimon match for age, BMI, intelligence, every other socio-demographic you can think of, same number of other medical conditions or no medical conditions or psychiatric conditions, and they both report sleeping 6.5 hours, and they're eligible for a study we want to do on people who say, I sleep through the night. I don't wake up, I sleep through the night. We have two candidates here. Well, Reuven shows this very consolidated sleep. Now, this is what's called a hypnogram. And we're not going to focus on all the different colors and lines, which represents different stages of sleep. We're going to focus on REM for now. And what we see is these very consolidated green bars in the middle of the screen. And these represent REM segments. This hypnogram would be about 7 hours of sleep. And if you look at the, if you look at the length of these segments, they're close to 15 minutes or longer. So keep that in mind. Reuven reports he sleeps great, feels great in the morning, actually doesn't even drink coffee in the morning, has energy pretty much all day long. So this is what you'd expect from high quality sleep. Shimon, on the other hand, sleeps all night, but feels tired in the morning, and in fact is sluggish throughout the day. And what do you notice? I apologize for the haziness of the slide. What do you notice about these green bars? They're all broken up. They're very short segments over here. Here's one that's a little bit longer, but then it gets broken up. And then again, more breaking up. This is a lot of fragmented sleep. So we would not imagine that to be high sleep quality. We would say, no, this sleep is broken. And we want to delve into what that means. And we want to ask the question, what exactly was going on in that REM sleep that was breaking it up? Why were those green bars for Shimon not consolidated, not running continuously? And the answer is the concept of sleep fragmentation. So on this slide, you see a 30-second time span. That's what the whole window is showing, just 30 seconds. And in sleep medicine, when you are awake for 16 seconds, that means that you're awake, even though you don't have any memory of it. You could be awake hundreds of times during the night for 16 seconds, go right back to sleep, and you would never know it. And that could be what's happening to Shimon as to why he would be so tired. There's also something called an arousal. It's only 10 seconds. But again, it's the same problem that you're asleep, but then you're awake, you don't know it, and then you go back to sleep again. There's even something called a microarousal, which is only 3 seconds. So these are the things in general that we see physiologically on the EEG of somebody who's sleeping when, in fact, their sleep is getting fragmented. Now, you might ask, well, what's the normal level of this sleep fragmentation activity? Like, do we have a little bit of it, a little bit? I mean, is there a way to measure it? And sadly, the field of sleep medicine is way behind in trying to understand this crucial element of sleep. There really are no norms that specifically say, well, this is normal. There are no norms to say this is abnormal. Of course, the more sleep fragmentation you have, like the slide we saw with Shimon, you're thinking, well, this clearly doesn't look normal, and this probably has an impact. And it turns out the downstream impact is what we look at more in sleep. And that tells us, well, whatever the sleep fragmentation is going on, this has some degree of correlation to those symptoms. Okay, so a very big question that everybody would ask and has been asking in research for decades is what causes this sleep fragmentation? And of course, everything on this list can cause sleep fragmentation. Some things cause more sleep fragmentation. Some things cause less than somebody might actually have appreciated before based on their training or based on their clinical experience or based on what they've read and understand about sleep. Excuse me. A larger question is that whatever is causing this sleep fragmentation is how do you want to define the activity? Do you say, well, if it was caused by depression, then it's a psychological change? Do you say it's psychophysiological? It turns out no matter what term you want to use, the bottom line is it's an EEG change in the brain. That's a physical metric of what's going on in your sleep. And therefore, that change in your brain from that arousal or awakening leads to brain damage. And I know when you hear this, you might think this is an exaggeration, but as we get into it, we'll see if you feel that way as we go forward. So daytime sleepiness tiredness and fatigue means your brain was damaged at night. It's not just that it didn't get the rest it was supposed to get, it's literally being damaged by having this fragmentation of sleep. I think we all know the importance of this problem with sleepiness. We only have to go back to creation. I mean, Hashem puts Adam to sleep. He wakes up and now he's got a wife and they're both really sleepy. And what do next? They sin. And they could have actually prevented all of this if they had just remembered on the third day of creation, God had created coffee. And coffee obviously is absolutely something that does treat sleepiness. And what's interesting is there is some research to suggest that the caffeine is reversing brain damage. That's a very important piece of information. But the second area is much more problematic. Sleep fragmentation causes a very specific problem because you are sleeping and waking up, sleeping and waking up. And that means your sympathetic and parasympathetic nervous systems are being overly activated throughout the night. And they specifically cause this problem. Your blood vessels are supposed to be more dilated during sleep most of the night. When you have an awakening, they constrict. And if you're waking up or having arousals hundreds of times during the night, they're going to go back and forth like that. What does that produce? That sleep fragmentation triggers it. And this is the inner lining again. So this is the example right here. Endothelial dysfunction. If you're unfamiliar with this term, it's very important, not just in medicine, but in all fields of mental health as well, because we know this is very important for outcomes regarding both mental and physical health. Endothelial dysfunction means the inner lining of the blood vessels going to your heart, going to your brain, are going to be damaged. They're not going to work in the proper fashion that they're supposed to, and you're going to basically age faster than you ordinarily would because of this change in your blood vessels. Worse, the sleep fragmentation itself actually leads to another condition called oxidative stress, which some of you may be familiar with, that refers to how many biomolecules inside the blood flow are actually transformed into more damaging molecules because the way the blood flow is being interrupted or because of the damage in the inner lining of the blood vessel. This leads to many, many problems. Sleep fragmentation is associated with hypertension, heart attacks, strokes, cognitive decline, neurodegenerative disease, dementia. So having sleep fragmentation that's doing all of this while you're sleeping, and you may not know anything about it for years until you get sleep tested or have some other mechanism that would allow you to find out what is going on in your brain while you're sleeping. The third area, and the newest one that's only been in the research literature for 10 years, and the depth and breadth of it we still don't even understand yet, is that your brain is supposed to clean itself while it's sleeping. It actually has its own janitor. It's called the glymphatic system. Some of you may have heard of this. It's very, very new research. There's even really no specific clinical implications or interventions yet, except for the fact that you want it to work well, and it turns out it works well when you're sleeping. It's a specialized lymph drainage system. It clears waste from the brain. It's been plausibly related to the removal of toxins like amyloid in your brain that could lead to dementia. It's been linked to producing the restorative nature of your sleep. And therefore, when is it most active? Well, not just while you're sleeping and not just any old sleep, but the deepest sleep is where you produce the best brainwashing. And you may know the names of deep sleep as delta, stage 3 non-REM, or slow wave sleep. All of those are good terms. And this is what it would look like. The top graphic shows these slow, high amplitude, low frequency waves that are an indication of much deeper rest compared to something like what is below stage 1 non-REM sleep, which is obviously much more higher frequency and of a lower amplitude. Now, getting into something more specific about sleep and mental health brings us to the question of what goes on in REM and what might be the reason for its importance in mental health. Because we gave you the example earlier showing REM fragmentation. So why is REM important? So a lot of research has been done on REM, and even though we can say the stuff I'm going to put forward right now has not all been consistently proven every single time in every research study, the consensus that's forming about REM clearly points to the things you're going to see on this slide. REM consolidates memory. REM helps process emotion. REM facilitates learning. Does that remind you of anything? A patient walks in for a therapy appointment. They discuss with you a memory that they have had. They then work with you on processing the emotion related to that memory. And then you're hoping they're going to learn a new insight from that experience that's going to help them move towards recovery. So REM sleep appears to function like a personal therapist in residence that you visit every night when you're sleeping well. As I mentioned before, the average length of REM of normals is about 15 minutes. Could be a little bit lower, but obviously could go even to much longer time for certain people at different times of night. If you can see this close up, this is what is called a rapid eye movement. It simply means that sensors were put by the corners of the eye and there was a deflection up and down because the eyes are moving very rapidly to the left and to the right. Here is an example of what this might look like. On the bottom, you see what's called tonic REM, and there are some rapid eye movements coming into the picture. And that's what we would look like that's what we're looking at when we're watching a patient sleep. We're seeing these rapid eye movements. And when there are more rapid eye movements, we call that a higher REM density. And that is often associated with a better REM response for whatever condition you might be looking at, whereas lower REM density, less eye movements, is thought to be unhealthier. So this is the goal. This is what we would be looking for our patients if they don't have this. This is what we'd be trying to appreciate, because we anticipate that if it was consolidated, we're going to get this response. Now, just as an aside, I'll throw out an example here, and I would have normally asked the people to respond, but in the interest of time, I'll just ask you to reflect on it. Here's somebody whose REM is at the very end of the night. And that might seem a little bit unusual, but technically it's not that unusual in the field of psychiatry, which is the first hint or clue I'm giving you. Why is this happening? Why is the REM at the end of the night? And the answer is when people are treated with REM suppressant antidepressants, you can look long and hard into the psychiatric literature dating back 50, 60, 70 years, and they discovered that if you suppress REM sleep, you actually will get a better response in the treatment of depression. That's actually how they used to do it a long time ago, testing out drugs in this particular manner and then testing patients who were responding. But what's never been tested, to my knowledge, I could be wrong, I don't follow this part of the literature. I'm unaware of what has been evaluated on what happens to somebody who's been treated for the depression, who has their REM suppressed all night long until the end of the night, what have they lost by not getting this REM? I do not believe that research study has been done yet. If it has been done, I've certainly not seen it. And I don't know if it would be done at a level to actually explain it. It'd be a very difficult thing to discern when you're talking about people getting the benefit of not being depressed versus what are they losing from actually not getting their normal REM sleep. Something to think about. All right, so let's go back to the fragmented sleep and ask the question again, why else might it be so important? And the answer, of course, would be you would not consolidate memory, not process emotion, not facilitate learning, and therefore the therapist in residence is not working. And that could be a very big deal. And research is certainly moving in that direction as we understand REM. But I'm going to give you something that is so dramatic in terms of proving the importance of what we've just talked about, that you're going to wish, just as I would wish, that every single patient you see from the past 3 months and every single patient you see for the next 3 months, you want to know what their REM sleep is doing. That's how dramatic this research was done by Dr. Thomas Mellman 20 years ago, conducting sleep studies on early trauma survivors and looking at changes in REM sleep in the relationship to PTSD. So in this first study, most of the individuals were in car accidents. They had no past history of a psychiatric disorder. He got sleep studies in general within 2 weeks of them having been traumatized. He excluded people with other prior, risk factors for other sleep disorders like snoring, apnea, obesity. And then he repeated the sleep studies and also evaluated them for PTSD. And the results are phenomenal. The bars you want to look at are the yellow ones. Those yellow bars refer to the segment of REM. How long is the REM segment? And in the PTSD patients, it dropped all the way down to about 7 minutes of the people who ended up getting PTSD in this study. And the people who didn't get PTSD or had very minimal PTSD, they remained above that 15-minute average we mentioned earlier. And in a control group he had of normals, they also pretty much the same. This is a phenomenal study, and it was repeated, producing this result. Essentially, this was what those normals and non-PTSD patients would have looked like. He repeated the study, same type of protocol. Findings are not as dramatic as before, but still noticeable and very significant. The no PTSD group gets to about 15 minutes per segment of REM, and the PTSD group cannot even make it to 10 minutes. Even more remarkable in this study is something that, depending upon your statistical background or what you know about correlations, they actually demonstrated a biological measure, meaning the duration of REM sleep, correlated with a very advanced scale. You're probably familiar with the clinical application of the PTSD scale, the clinician's application. One of the most reliable PTSD measures, and it showed that the longer the REM duration was, the smaller the score was going to be for PTSD. So that's a very big deal when you can correlate a biological metric with a validated psychometric scale. And that's what they were looking at, this fragmented REM sleep. Okay, now, the big question that always comes up, and probably has come up for all of you many times in your careers or in your training, always wondering about, well, what would be a cause of sleep fragmentation? Because you're always hearing about people talking about awakenings, and having trouble staying asleep. And right before our eyes, we should look at the fact that if something does seem physiological, then perhaps it is. And it turns out that sleep disordered breathing is the single most likely etiology to explain the severity of sleep fragmentation observed in a patient who is not responding to treatment. Now, when I say not responding, I'm referring to conventional sleep therapies like getting a medication, being instructed on sleep hygiene, getting psychotherapy, getting CBTI even, and not responding. I'm even talking about patients who say that their psychotherapy isn't going that well, or that their psychotropic medications are not going that well, and they just are not responding the way you would have predicted. Obviously, you see many patients that are doing better. They're improving, they're doing well. And you're always looking at, well, what about the patients that are not? What is the explanation? By the way, if you need something to consider as a metaphor, it's absolutely abundantly clear that sleep disordered breathing that's not treated is exactly, or not, I shouldn't say exactly, it is a parallel course with what happens to a person who smokes a pack of cigarettes a day. All that same damage that we're talking about to the inner lining of the blood vessels, to the brain, to the heart, and so forth. Sleep disordered breathing can do all of that. Now, let me give you a really quick tidbit to drive this home. And this researcher, Dr. Christopher Rice at Long Beach VA in Long Beach, California, if you want to follow this research, he continues to do studies like this. They did a study looking at the use of exposure therapy and PTSD patients, and they separated the group. This is published in the Journal of Traumatic Stress. They separated them into the patients who didn't have sleep disordered breathing, SDB, sleep disordered breathing, and the ones who did have sleep disordered breathing. And as you can see, the ones without this breathing disorder had a 58% reduction in PTSD symptoms following exposure therapy, whereas the 6 patients with sleep disordered breathing untreated essentially had no change in their PTSD. So that's how big a deal this is. And what I want to do now is go back in time and talk about a little bit more regarding sleep apnea, so you have a context to understand not only why this condition is so important, but why, in terms of modern healthcare systems, it's actually very difficult to treat. Sleep apnea was discovered in the scientific literature in the 1960s. This, by the way, is Rod Taylor in the 1960s movie The Time Machine, the famous story from H.G. Wells. In the 1980s, we'll use a different time machine from Back to the Future. This is the DeLorean motor vehicle used as the time machine. This is when CPAP was discovered. And so the invention of CPAP became the first consistently efficacious treatment for sleep disordered breathing. And that led lung doctors, pulmonologists, and sleep technologists to start opening sleep labs, and you have a booming business in sleep medicine in the 1990s and the 2000s. During that time and going forward, as the business expanded, health insurers and government regulators began to assert more influence over the field, creating a number of difficulties. The first difficulty is the idea that an insurance company can decide the definition of what it means to be diagnosed by sleep disordered breathing. For the obvious reason is that if you can have a more constricted or restrictive definition, then you have fewer people you have to cover for that condition. This is very common in America under the influences of Medicare. The second thing is the application, or the sort of the almost a mandate that CPAP is all that's needed for PAP therapy. CPAP should work for everybody. There's not a reason to consider other treatments. If the CPAP isn't working, you've probably heard this from your patients who've said, well, the doctor told me to just keep using it. or keep trying to use it, and eventually it'll kick in, and eventually it'll work. Both of these two elements are very problematic and have led to a very sharp decline in the field of sleep medicine because they've held to these parameters for way too long. And we'll explain more about that. So let's talk about breathing just so it's clear what we mean. This is normal breathing. If you look at the top, the airflow curve is rounded. If you look at the bottom, the airflow curve is rounded. So this is breathing in, this is breathing out. This obviously is really, really poor breathing. There's no breathing. And notice what happened at the end of this event of obstructive apnea. Look how dense the EEG becomes, because that's the arousal activity. Back in the 1980s, sleep apnea was the only breathing event permitted for the diagnosis of a sleep apnea condition. Later in the 1990s, they came up with what's called a hypopnea, where instead of stopping the breathing, it was a 50% reduction. And then later, we learned something very interesting for mental health, which is this third breathing event. This is where there's tremendous controversy, conflicts, even adjudication, so to speak, in trying to help patients, because these kinds of subtle breathing events appear to be more common in mental health patients. You can see that the top of the airflow signal was cut off, and just above it was snoring. Now, show you the same thing. Here, the top of the breathing event is cut off, but there's no snoring. So here's a little aside. Snoring is a relatively useless term or symptom or sign to be using to evaluate sleep-disordered breathing. The only value it has is when somebody is a loud snorer. That means they likely have sleep apnea. Everything else about snoring can be ignored. There are literally millions of people who don't snore at all who have sleep-disordered breathing. Many mental health patients don't snore and have sleep-disordered breathing, and a lot of it looks like these flow limitation events. Here's a close-up of this, and again, you see the top of the airflow signal is cut off, and then there's this increased density in the EEG. The person wakes up, and the breathing returns to normal. Now, how important is this? Well, I'll show you a study that we did specifically on this concept. For decades, nobody had done any research up until this study in 2012 on why insomnia patients wake up. It seemed like it'd be a very important study to do, like insomnia patients are always complaining about awakening, and the most common form of insomnia is individuals who can't sleep through the night. As we talked about previously, falling asleep is obviously a problem, but the older you get, the falling asleep subsides, and it's more about you can't sleep through the night. We wanted to do a study on chronic insomnia patients who we knew could not have sleep-disordered breathing. So what did we do? Well, we found 20 people who were not sleepy, they did not have obesity, and they had no breathing symptoms. So we would expect them to not have sleep-disordered breathing, but yet we wanted to evaluate their awakenings at night. And what did we find out? Well, they averaged 25 awakenings per night on their sleep study. And remember, an awakening could be that 16-second interval of arousal activity that's by definition an awakening. Normal at the time was alleged to be maybe 8 awakenings per night. Again, we still don't know what normal is for awakenings. But if that's the case, 25 is 3 times the normal level. And what did we find? Well, leg jerks woke some people up a little bit. Spontaneous awakenings, just being in the lab, 90% of their awakenings were preceded by a respiratory event. And the most common event that they had, more than half of them, were these UARS or flow limitation events that I showed you, they're much more subtle. So what are we dealing with here is a very, very physical phenomena that is going on in the brain of the people who are sitting across from you that you are trying to help. You would love for them to have the normal deep sleep up above, but what I'm suggesting, and I hope you'll reflect on this, is that the individuals you're looking at may look depressed, may look in despair, and no doubt they are, and they have been traumatized, but there's a very good chance, a very, very strong chance, even in this 3-month window we're talking about, that they are suffering sleep fragmentation. They are suffering this pattern on the brain below, and the question is, can we do something about it? So we're going to talk about PAP for a little bit, just so you have clarity about the most common treatment. Positive airway pressure therapy, there's different kinds. CPAP means continuous. These other names are bilevel, auto bilevel, adaptive servoventilation. And what they generally mean is this. When you use a CPAP device, it's one pressure whenever you're breathing in and out. So let's say somebody gets something called an auto CPAP device. It's still one pressure. When it switches from 8 to 10 or 10 to 12 or 12 to 4, when you breathe in, you get the 12. When you breathe out, you get the 12. All the other devices are bilevel, and they're much more natural, much more physiological. And 30 years ago, it was shown that you can normalize the airflow better, or certainly more easily, by giving somebody bilevel where it's a higher pressure breathing in, which is very comfortable, and then a lower pressure breathing out. In fact, just so you're clear, the reason most people cannot use CPAP, the reason we stopped using CPAP in 2005, unless forced to by an insurance company, was that this expiratory intolerance, trying to breathe out, would cause claustrophobia, traumatic sensations, panicky sensations. People would rip the mask off. They just could not get used to it. Now, there's many other aspects of PAP that people have to adapt to, but this is probably one of, maybe the largest one, and that got us switching to these other devices that I mentioned. So here's just a quick hit on a study we did and published 7 years ago using these advanced PAP machines for people with post-traumatic stress disorder and comorbid sleep apnea who all failed CPAP. This was 147 patients who walked into our center. They had failed CPAP, and we put them on these other devices. And what you can see in this graphic is these people in this section went from failing CPAP and not using a PAP machine to using a PAP machine averaging more than 7 hours a night. This was about 100 of the people we had data on. Of the 130, actually, we turned into users. So 60 people were averaging more than 7 hours a night. And here's another 20 people who are averaging about 25 hours of PAP a week. And so in the literature on PTSD, it's very common to find people only averaging like 25% compliance to being able to use it. Compliance meaning using it on a regular basis. Another study we did showed that if you bring somebody back into the sleep lab and regularly titrate them and work out the kinks and the pressures and the mass problems, you can actually do a great deal to get them to use. This is, again, 273 CPAP failure cases, of which 200, almost 200, became users of a PAP machine, auto bilevel or ASV. And these users ended up showing a much greater percentage of REM sleep and much more REM minutes of sleep than the people who are non-users. Now, I always like to credit people because Ecclesiastes says there's nothing new under the sun. These are very famous researchers from Pittsburgh, a very famous psychiatric group that was very interested in sleep, especially in the 1980s and 90s. And look at this quote. Back in 1982, they hypothesized that a relationship between sleep breathing and mental health disorders might exist, particularly in relationship to rapid eye movement. And we quoted this paper in 2002 in our paper on this topic. Then in 1998, this is the most remarkable case report describing a miracle cure of a person had PTSD, suicidal ideation, multiple hospitalizations for his mental health conditions, using multiple psychotropic medications, walks in and gets an evaluation. Look at the number of arousals this man was having. 600 arousals per night. Treated with CPAP, it drops to 36. His amount of time spent in REM sleep doubles from 11% to 21%. And in this case report, PTSD is gone, suicidal ideation is gone, nightmares and insomnia are gone. And the patient's report is, I'm now sleeping all the way through the night and everything has gotten better. Now, obviously, every patient doesn't get that response, but to see this and to have it been reported is very important. And now we know from other researchers that are getting on board with this. Dr. El Sol in Buffalo, New York, is a very good doctor to be following his research. He's already published a paper showing the number of CPAP hours in use by the patient leads to, that's what this line is showing, the absolute change in PTSD score, and the correlation is clearly showing. The more hours you use the CPAP machine, the greater the improvement in the PTSD. Highly significant. This is a very high correlation, 0.45, for something where you're measuring, again, a psychometric validated score against a biologic metric, CPAP use. Here's his extensive quote. The phenomenology of PTSD is heralded by an underlying REM sleep dysfunction, amplified by OSA, repetitive EEG arousals, meaning the sleep fragmentation, induced by recurrent hypoxic episodes. I would only add that it's not always hypoxic, but we can get into that in the Q&A, that disrupt emotional reprocessing of traumatic memories that occur normally in REM sleep, which should be functioning then to reduce their impact on current cognition. CPAP promotes consolidation of emotional memory, which may assist in the recovery from trauma. This means that the next patient you see who has this problem, it is possible that is what's going on and that they will need this kind of treatment. Now, it's not easy to get this kind of treatment, but I just want to make it crystal clear that absolutely this is part of this process that could make a major difference in helping people not get PTSD or helping people recover from the PTSD they're currently experiencing. Now, as an addendum to this, we published a paper 5 years ago. Most of the patients in this study were mental health patients. Close to half of them had post-traumatic stress. It's not a PTSD study, it's a chronic insomnia study. And it dealt with the fact that we wanted to prove that if you're going to use a PAP machine, and we've been saying for years that the CPAP is very difficult for people to use, we wanted to prove that these more advanced PAP machines will in fact do a better job. And this one slide shows that. This is a sleep quality metric, a scale where people are self-rating their sleep quality. Most normal sleepers will rate their sleep quality between 80 and 90%. You can see the red line, which is the ASV, the most advanced sleep PAP device on the market today, that fairly quickly, within 4 weeks, and that's when people started telling us they were getting better, within 4 weeks, it separates from the sleep quality changes in the CPAP device. It gets up to nearly 80% by the end of the study, 14 weeks later. And the CPAP group can't even get just above 60%. And the bottom line of that is as follows. In the ASV group, 70% of the people were cured of insomnia. And what I mean by that is that on a very well-known insomnia validated scale, there is a cutoff that says if you hit this cutoff, you don't have insomnia anymore. They fell far below that cutoff. 70%, 7 out of 10 people were cured. In the CPAP group, again, to the credit of CPAP, you can get benefit, but again, it's only 2.5 out of 10 people were cured of insomnia. And so this is why we've always talked about insomnia as being a sleep quality disorder. We want to think about it in terms of the numbers of hours of sleep because the patient walks in the door and talks to us that way. But we have enough information now to sit down with the patient and say, well, yes, number of hours in sleep is relevant. It can be important, but we need to know what the quality of your sleep is, and we've got to figure that out and do something about it if that's the source of the problem. And just so you're clear, when I see chronic insomnia patients who are struggling to whatever treatments they've tried, CBTI, sleep hygiene, medications, their chances of having a sleep breathing disorder or something else physiologic going on with their sleep are greater than 90%. That is how common this is. So this is extremely relevant to the people you're seeing now and will be seeing over the months to come. So I want to give you one last case history. We'll run through this quickly to give you an example of how this works. This is a sad example with a happy ending, but sad because this took close to 2 years. This is back in 2007 when we developed this case history to demonstrate the phenomena. You recognize the pattern of REM on the bottom. This is somebody who is diagnosed with sleep apnea. And notice all the fractured REM sleep to the point, if you counted each fractured episode of REM, that was 22 REM periods. And we say, how many minutes of REM did he have, and divide it up and go, well, let's call that a REM consolidation index. And obviously we want REM to be so consolidated that these measures are going to be 15 minutes in duration. So the patient comes back for a bi-level device, actually doesn't do that well, and pretty much has the same REM consolidation. You can see all the fractured REM on the study. But now they're switched to one of the more advanced devices, auto bi-level. And you see for the first time, noticeable expansion of the segments. This is all the way up to nearly 10 minutes per segment. And of course, timeline, this is what happens when you're dealing with insurance companies where a person comes in for a study, they try a device, they come back and they say, well, it's not working, what do I do? And the insurance company says, well, they've only had this a short time, bring them back later. Everything is just constantly delayed. The patient also gets discouraged. The patient thinks, oh, well, this must be as good as it gets. Do I want to bother them again? Maybe there's nothing they can do for me. This is how this plays out. Like I said, it's very sad. Finally, this person undergoes what's called a split night protocol, which in America is something that we still have to do to qualify somebody for this most advanced device, ASV. And look what happened to their REM sleep. Segments going up to 20 minutes on average. And this is a REM rebound effect. If you ever heard of that term before, REM rebound. And that means that their REM had been stifled all this time, but with ASV, because it perfectly normalized the airflow, or as close as it could get to perfect, all that REM came back. And then as a follow-up, 6 months later, now they had quieted down a little bit to normal REM stages, and you can see it's still holding up. A REM consolidation index above 50 minutes. This is what we're looking for in our patients, and this is what we worked on at our center in New Mexico when we had our lab open there for 20 years, and often found that we could improve REM consolidation and see clear-cut changes in mental health, physical health. So what's the summary of this? Sleep fragmentation is a sizable missing link in mental health care. Sleep fragmentation destroys both sleep quality and REM consolidation. Sleep disordered breathing appears the most likely factor in sleep fragmentation. Sleep disordered breathing induced brain damage causes or worsens mental health. Treatment of sleep disordered breathing will improve mental health. And that's absolutely the wave of the future. And we're trying to help people to get on that wave and expand it. If we theorize this very specifically now to the idea of REM, we should ask, what if the REM sleep fragmentation observed in PTSD, because this has been described in many other research studies. So what if it's observed in PTSD and other mental health disorders, anxiety, depression, is actually a function not of the mental health disorder, but really of the sleep apnea, or another term, upper airway resistance, for those more subtle breathing events. And obviously it could be both. So how is this relevant to the practice? Well, as we mentioned before about the exposure therapy example, if somebody is having deficits of REM, would you be fighting an uphill battle with your patient? They have broken sleep, they have fragmented REM, and you're trying to help them with psychological breakthroughs in therapy, or you're trying to help them with medications and they're just not working. And this likely is, in many of the situations you're seeing, the explanation. And then, of course, the big question is, how do you engage with a patient to get involved with this part of medical treatment for a condition that you want so desperately for your patients, because it's going to help their mental health? And that brings us to the last part of our discussion, which is an area that I hope is pleasantly surprising for you. Because most people, when they hear about this topic, there's a tremendous degree of frustration. You have probably, most of you, if you have clinical experience, have heard the frustration, the anger, the sadness, the vexation of the people who can't use a PAP machine, or they've used it and they get no benefit. It's very, very common now for people to report these problems. So, can you wave a magic wand and suddenly get them on an auto bilevel or ASV machine? No, you cannot. But you can do something else in the early phases of this process for people who are currently failing a PAP machine, or people who've never even heard of PAP. Because once you figure out, and we'll go into this more in the Q&A, once you get the sense, it's very easy to learn this, once you get the sense that somebody may have a sleep breathing disorder, in your situation, even though your background is mental health has always had a very, very long tradition of talking to people about their breathing, about using breathing to relax, about breathing to overcome anxiety. This is just going to be an extension of that, because it turns out that if you're willing to work on helping people improve their nasal breathing, you're going to discover it's going to help their mental health. Irrespective of PAP, irrespective of anything else, you can actually see changes within 2 to 4 to 6 weeks in numerous patients just by evaluating things such as, do you mouth breathe? You ask somebody, do you mouth breathe? You ask somebody, do you have chronic congestion issues? Here's the catch. Because chronic nasal problems, nasal breathing problems are so common, what do people do? They normalize it. People normalize their breathing, and before they would even think to have a discussion about it, you might have to sit there and say, can I listen to your breathing? You could be watching somebody who's mouth breathing, and you could say, do you mouth breathe? And they could say, no, I don't mouth breathe. But you're looking right at them and you're watching them and you know they're mouth breathing. Okay. So you'll see as we go along with this, it's a simple conversation for one reason. It turns out that most people with sleep disordered breathing have a high degree of nasal congestion. Now, if you think about it, it's actually really obvious why. What is sleep disordered breathing? It is a friction, an obstruction, a resistance inside your nose that's happening to you every time you sleep. That means the mucosa inside those tissues, your nose, your upper airway is what we're talking about, are actually irritated. If you do a biopsy on the tissues for somebody who has sleep apnea, you find horrible inflammation in these tissues. So that's one of the reasons why the nose is so susceptible to having allergies, congestion, and other types of symptoms that we'll talk about now. Okay. General treatment plan. A person should have zero tolerance for nasal congestion. They should be able to breathe through their nose. It's like getting in a shower, a steam shower, clearing out your nose, walking out of the shower, taking a deep breath through your nose and going, oh, that's how I'm supposed to breathe. Okay, well, unfortunately, people may try allergy medications, but I don't find them to be consistently as effective as what we're going to talk about. Some people do have resistance and reluctance about putting things into their nose, and it may take, in fact, psychotherapy to get them to the place to use these things. But there are patients, I'll just make it very clear, if you can get somebody to use nasal saline rinses for their congestion, and they agree to do it, and sometimes that means doing it 3 times a day, 5 times a day in the beginning, they can come back to you in 2 weeks and tell you they're sleeping better. They don't believe it, but they're going, this is crazy. I've been using those saline rinses and I'm sleeping better. Same thing with neti pot washes. Same thing with people who have chronic sinus problems, which is a lot more complicated, and we'll get into that. But what we're getting at here is that nasal hygiene is extremely potent if it's used regularly. So it's very important to get this idea. If the person believes like, okay, well, I'd like to have a clearer nose. That sounds like a good idea. I'm in. Let's go for it. All right. Now, this is where it gets the trickiest. Most people will talk to you about the term allergies. There's a condition called allergic rhinitis. And by the way, excuse me, a lot of what we're talking about, I go into even more depth in a video I have for free on my website, BaryKrakowMD.com. It's called The Nose, N-O-S-E, Nose, K-N-O-W-S. So people think that everything is allergies, but all you have to do is ask one question. You go, so these allergies, this congestion you have, do you have it all year long? As soon as the person says, oh yeah, I do, it isn't just allergies, because very few people, you can have it, but very few people just have allergic rhinitis that isn't mostly seasonal. That's why they get that name, seasonal rhinitis. Nonetheless, anybody who starts out will usually say that it's allergies. As you learn about this, you'll be able to pick and choose between what's called allergic and non-allergic rhinitis. And if you've heard of nasal steroids, it's the most commonly used treatment for this problem of congestion. Nasal saline can help. Certain over-the-counter sprays can work. If you've heard of Flonase, it's actually done research showing the treatment of sleep-disordered breathing. Remember, we talked about 2 breathing events, the apneas and hypopneas. By the way, that's the index people use. It doesn't even include that 3rd event, the flow limitation I've been talking about. You actually can decrease someone's apnea-hypopnea index just by starting them on Flonase, proven in the scientific literature. So now you have a good explanation for why somebody would come back to you and say, I'm sleeping better, because you've actually reduced their sleep-disordered breathing. Okay, this is the biggie, because non-allergic rhinitis is incredibly common, and particularly so in mental health patients. So you're going to find tons of patients with allergic rhinitis and non-allergic usually lasts all year long. These people often say very specific things like, my nose is runny, or I get post-nasal drip, or my nose is stuffy. And they don't report the allergy symptoms of sneezing or itchiness. And so, sadly, many doctors do not make these distinctions. They actually don't think about it. They've not been trained to think about it. I was fortunate to learn about this in medical school, so I always had my eye on it. And amazingly, just in the last 20 years, they have actually come up with treatments that work very, very well for non-allergic rhinitis. In the past, they did not have anything. All right. Another way to know about non-allergic rhinitis means the patient says to you, well, I've used the sprays, I've used the pills, and I still have the problem. So that's another example. And by the way, anxiety and non-allergic rhinitis seem to go hand in hand. Remarkably, it actually seems as if anxiety may be a causative factor in getting non-allergic rhinitis. What we know more commonly are things like dust, wind, weather, temperature changes. Great example. Somebody has a PAP machine on. That's wind blowing up their nose. If they suddenly get stuffy, you know that they can't use a PAP machine. They need to stop and treat that condition and then restart. Even food can cause that kind of rhinitis. The non-allergic rhinitis diagnosis is delayed for years, sometimes decades, because people do not go into these details. And if you're in sleep medicine, you realize very quickly you've got to go into the details because the patient can't use the PAP machine. Let's see. So I've said often co-occurring, failure of allergy treatments, anxiety associated, and then one other pearl. If you have patients with reflux, reflux can cause non-allergic rhinitis. And silent reflux, a condition where you don't even know you have the reflux, can also cause non-allergic rhinitis. So that means that some people...
Barry, I'm interrupting you for just a second because many of
Sure.
our audience are not physicians, and reflux is a very technical term. Reflux in Hebrew, צרבת או הפרשת חומצה מוגברת מהקיבה. Sorry, go on.
Okay, we good now? Okay, thank you. And so sometimes a throat doctor has to put a tube into the throat and actually look at the esophagus to find out if this reflux is going on. Okay, so non-allergic rhinitis is so confusing because it's a disorder of overstimulation. People who use too much of these nasal sprays and come back and say everything got worse, again, they're telling you that's the diagnosis of non-allergic rhinitis. They have to stop all treatment and start over again to try to figure out what to do, the least amount of treatment. And these are the newer sprays that I'm talking about. Astelin, Astepro, Patanase, I don't know what's over in Israel, but antihistamine nasal sprays are one of the best treatments for non-allergic rhinitis. There's an over-the-counter nasal spray called xylitol that may work for it. And there's an older drug called Atrovent that may work for it. And interestingly, if you're on the antihistamine nasal spray, it might treat the allergic rhinitis as well. So improvement in nasal breathing is highly likely to yield a decrease in mental health symptoms, large dividends with just a simple treatment paradigm. And then last on this subject, you're going to find many patients over time that you're going to want to refer for ear, nose, and throat evaluations, or depending upon your resources, get the evaluations done in your own office at a limited scale, finding out about deviated septum, swollen turbinates, and large tonsils, and so on. And you can imagine how important this would be in children. And sinus problems, as I said, are very complex, and these people need a lot more attention because many of them do have sleep apnea, but the sinus problems are often best treated before they try the PAP therapy. Okay, now here's the last part of this, and this is not the miracle cure, but if you want to talk about something that will produce the most bang for the buck, are these things that you can put on your nose. Let me show you a quick picture. There's the nasal strip, and on the right is the nasal dilator. We did a study published, almost 20 years ago, and these were chronic insomnia patients who we knew probably had a sleep breathing disorder. They didn't know that. And we said, why don't you try these nasal strips And at the end of 3 months, 75% compared to the control group, which had no improvement and did not use a nasal strip, 75% reported meaningful, clinically meaningful changes in their insomnia just by using a nasal strip. Most people actually see results in 2 to 4 weeks by using a nasal strip. Some people think the response is so good with these things, they actually think this is all they need. They don't even think they need a PAP machine. They've had such miraculous responses, particularly so with the nasal dilator. The problem with the nasal dilator, of course, is you have to find people who are going to be receptive to placing this in the nose. And it takes a period of adaptation. And so it's usually much more difficult to convince somebody. Nonetheless, extremely potent, these two therapies. When you start recognizing sleep disordered breathing in your patients and you start talking to them about congestion, which, by the way, I'm not recommending these so much for the congestion aspect. I'm recommending that's a separate treatment plan to improve the congestion. And once there's some improvement in the congestion or stuffiness, then as they apply these, they will get a much more noticeable benefit. If they try to use these while their congestion is still a problem, they might not think that it's doing that much for them. Extremely potent treatments. All right, let's wrap up now with some consolidating information. All of this time over the years, people have always imagined that insomnia was something that produces sleep fragmentation. Nobody's surprised. But what most of us didn't know and didn't realize until 1994, when somebody actually published a study proving sleep fragmentation actually worsens airway collapsibility. So all this time that we've been wondering about PTSD, anxiety, depression, nightmares, and so forth, everything causes sleep fragmentation. And all of it causes airway collapsibility worsening. What do you end up with? Sleep disordered breathing, either etiologically or it's worsened. And then you have this whole cycle of worsening sleep fragmentation, more collapsibility, more sleep disordered breathing, more insomnia, and so on. Mental illness then causes sleep disorders. Not a surprise. Sleep disorders cause sleep fragmentation. So do mental illness. Sleep fragmentation causes airway collapsibility. Collapsing airway causes physical sleep disorders. Physical sleep disorders worsens mental illness, and so on and so on. These things are joined at the hip. We may never get to the place anytime soon about the chicken or the egg, which came first, but they clearly are joined at the hip. This information is absolutely crucial for so many of the patients that are struggling in the long term, but you're going to find many of the newer patients that are struggling with sleep and many of the people who recently had good results, this will be applicable to. There's a breathing condition going on, and the nose can be the first place to start. As you remember, when we started this program, we said sleep is for two things. I hope I have engaged you today in a way to understand why sleep is so important for the healing component. This physiological improvement that overcomes sleep fragmentation and produces sleep consolidation is what heals mental health. We've not covered some things on oxygenation, leg jerks, how to assess for sleep disorder breathing, how to refer for sleep testing, and we can come up with some of that in the Q&A. And since we've gone over a little bit, we can spend a little bit longer on the Q&A if you like. Don't sleep on these sleep interventions. Thank you very much.
Thank you, Barry, for this immense amount of information, and I'm eager to try some of these questions and tactics on my patients, as the previous talks really gave me some good points with my patients. There are a lot of questions regarding all the topics you've covered in this talk. Shall we get right onto it?
Absolutely.
A few questions that came in various variations is how to think when to send someone to a sleep lab, and what's the indication to do it, because we can't send everybody. You know, it's already in Israel. It's a real problem. It's quite kind of a long queue, I think, and not everybody can go there. So, what do you
Right.
think? When do you think
So,
are the like red flags patients should go there?
so the most, I mean, this is going to sound, I'm not trying to be rebellious here. The answer is more sleep labs. They have all of these things called, home sleep testing. And so there's going to have to be an expansion at some point where more and more people can get these home sleep tests. And unfortunately, what you're going to hear in the form of pushback is the idea of, well, how severe is that case? How severe is this? We only have time for these really severe cases, the people with congestive heart failure and heart attacks and strokes and so forth. And I don't have a solution to that. That's why I say it is so important to start working on the nasal breathing first, because if you do that, you're moving the person into a self-empowering situation. Once they taste better sleep and realize, oh, there's something going on here, they're going to become their own advocate. They're going to push to get their sleep study because they go, no, this is part of the problem. I want this problem solved. When there's higher demand, usually a health resource turns around and begins to realize, well, we've got to create more opportunities for people to get tested. Now, there are some simple ways to quickly ask the question, do I think this person has a sleep breathing disorder? The first question that you all would have is, how have they responded to their treatment? If somebody didn't respond to psychotherapy and medications and they're sleeping horribly, that's the first huge red flag. There's something seriously wrong with their sleep. But you can get into other details that are very simple. Did you know that many people, these are not like every single patient, but many people who wake up in the morning with a headache have sleep apnea? I don't remember. I sent Ido a 8-minute video. I think it's on my website too, but I sent a video that can be sent out to everybody. And it describes this phenomena about early recognition or easy recognition of sleep disordered breathing. So one example is, with sleep apnea, carbon dioxide builds up in your brain and causes your blood vessels to open up. And when the blood vessels open up, you end up getting a headache. And so when you wake up in the morning, then that's what you're noticing is the headache. And you don't know what to make of it, but it goes away and you think, I don't know what that is. A great indicator of sleep apnea. Another one is somebody who's a mouth breather and wakes up with a dry mouth. Extremely reliable indicator. If you're mouth breathing while you're sleeping, there's an obstruction. You're not getting in enough air. A third one, which is unreal, and we've done the research and published on it. You can more reliably, or at least equivalently, make the prediction that somebody has sleep apnea with trips to the bathroom at night compared to snoring. So sleep apnea actually causes the body to release a diuretic. You know that term. A diuretic comes from the heart because of the strain sleep apnea puts on the heart. And now you start waking up at night to urinate, go to the bathroom. Sleep apnea treatment, even with CPAP, can completely reverse trips to the bathroom. So there's some examples of things you can ask. Obviously, you can ask about daytime sleepiness, but the problem with daytime sleepiness is very simple. You have sleep doctors trained to believe that all sleep apnea patients are sleepy. But in your experience, what did we talk about on seminar number 1? That this sleepiness problem is what's absent, is what's causing so many people not to sleep. They're not sleepy anymore because they're traumatized. That sleepiness has turned into exhaustion, fatigue, tiredness. sleep doctors have not heard this discussion point. They're going to go, what do you mean? They're supposed to be sleepy. They're supposed to be sleepy if they're going to have sleep apnea. And you're going to have to do some education of the sleep doctors to say, well, maybe, but my patient is exhausted. And one more, just to be clear, we talked before about this in terms of the inner lining of the blood vessels. If you've got a mental health patient, and many of you will have mental health patients with high blood pressure, whether it's treated or not, those people, the wave of the future says every one of those patients should get a sleep study, because virtually everybody who has high blood pressure probably has a sleep breathing disorder, unless you can point to something else to explain it. That's how common you will find it. And I'll give you one last tip. What I just said is so common that in America, I don't know about elsewhere, the cardiologists now know this. The cardiologists order sleep tests on almost all their patients now. Cardiologists are now thinking about opening up sleep centers in their heart hospitals because they couldn't believe, and now they see the epidemic of sleep apnea in people with heart attacks, arrhythmias, strokes, congestive heart failure, myocardial infarction. All of these people end up with sleep apnea. And so that's how big a deal. And so those people get it, and you have no trouble convincing them to have their patient get a sleep study.
That's really interesting. And taking it to PTSD, one of the questions that someone asked, does sleep laboratory should be a routine part of PTSD? I would try to maybe refine this question. If you have a PTSD patient that does not respond well, what are the chances that if you're sending him to get a sleep study, you'll get a positive response that gives you the answer?
Great, fantastic question. Fantastic question, because if those doctors, and this is a super controversial area, Dr. Christian Guilleminault at Stanford University, in 1982, this is 40 years ago, he discovered that third breathing event called flow limitation, upper airway resistance. And these are very important terms to remember, because when you talk to sleep doctors and you throw that term around, then they're going to go, oh, this person is educated. This person knows what they're talking about. He discovered this in children in 1982. He discovered it again in adults in 1991. I was fortunate to train with him at Stanford in 1993 in a mini fellowship program. I learned all about upper airway resistance. And yet, to this day, 30 years later, only 1/3 of sleep doctors actually pay attention to this. And if you ask the question why, it's because of what I mentioned before. If an insurance company has this much influence to make people think that this is the correct definition of a disorder, you actually have doctors, sadly, this is horrible in this day and age, who think to say to the patient, well, the insurance company says you don't have a disorder. So since I can't treat you, you must not have a disorder. And that conversation actually takes place in America all the time. And we saw patients for 20 years with this particular problem. I don't know what it's like in Israel regarding this particular thing, whether they rely only on the...
It's a bit better here.
Okay, so people have more awareness of the upper airway resistance. That's great.
And no. I'm saying the insurance medical profession relationship here in Israel is a bit better.
So you mean the communication can be better, perhaps?
Yeah, and doctors are less subjected to insurance decisions.
Okay.
Okay, we have a few more questions.
Sure.
Someone asked, does hypersomnia also related to SDB?
So in mental health, hypersomnia traditionally was talked about the vegetative state of depression, the depressed patient who slept too much. And that turned out to be not wrong. I mean, there are cases like that, but there's so many more patients with depression who have insomnia. The hypersomnia we see in sleep apnea is much more the classic sleep apnea patient. They may be depressed and they may have other problems. They could even have PTSD, but there's something about their wiring is that all that sleep fragmentation they have is not coupled with an anxiety response. So they end up really sleeping more. And that is a giveaway, a dead giveaway that that person does need a sleep study because you're not supposed to be sleeping too much. Now, can it be depression? Yes, but it can also be that there is a physiological change in the sleep that's causing the hypersomnia. But it gets so confusing because you don't usually see a lot of PTSD patients saying I'm sleeping too much. I'm not saying you can't see it, but it's not anywhere as common as I can't sleep.
There is a really important question. I think you can read it in several ways. Is sleep induced by melatonin or medication just as beneficial and effective as normal sleep? And I would say we know that the architecture, the sleep architecture, is being changed by sleep medication. But if you get that sleep, if you're using quetiapine, for example, to get patient to sleep, does the sleep has the same quality?
Yeah. The chances in general are highly unlikely they're getting the quality they need. Yet there are specific instances where you're talking to a patient who literally says to you, well, I'm on 7.5 milligrams of Remeron. And they go, I'm sleeping great. Well, I believe them. I don't try to like say something different. I go, well, that is so great to hear. So when you got somebody who's using a drug and it's working, and they say they're feeling good in the morning, they're functioning well, they're a very, very fortunate individual. And you would definitely not say to them, oh, well, you've got to get a sleep study. You're looking for the people who say, I'm on this medication. It's helping me sleep through the night. But you know what? I don't feel that rested in the morning. I actually do get up sometimes to urinate. I don't have a lot of energy in the afternoon. I feel like I need another cup of coffee right after lunch. All these things tell you that there's an energy deficit, and you got to ask, well, what is it from? Is it the sedating side effect of a drug? That's another possibility. But if that's not it, you very much do wonder what these medications are doing, particularly as we've talked about today, REM sleep.
Okay. Okay, I think that's very important to know. There were several questions about nose breathing. One of the physician, I guess, in the audience mentioned that the medications you suggested to treat congestion are mostly a short-time solution, and asked about, I'm sorry, long-term solutions. And someone complimented the question, saying that is the best available solution is it advanced positive flow device, and are there any long-term solutions which would be considered as the best solution? Any other more advanced solutions?
Right. So the most important thing to hear is that the field of sleep medicine is changing very dramatically because there's so many entrepreneurs, thank God, who are out there looking for other ways to treat this condition. For the longest time, we've learned that many people can use what's called an oral appliance. It's a dental device that actually holds the jaw forward, and you can get a 50, 70, 80, 90% improvement. I used one of these things for 4 years before I switched over to PAP therapy. I've tried all the PAP devices, and this is where it gets really tricky because I would want every single PTSD patient to be on auto bilevel or ASV. And the way we ran our sleep center in New Mexico, that's exactly what we did. We found a way to demonstrate this concept, which is called, as a key point, CPAP failure. And by doing that, the insurance companies understood our rationale and allowed us to get patients on auto bilevel and ASV much quicker. If you're dealing with certain situations where the doctors are not interested in doing this, they're going to tell you standard care is CPAP, CPAP, CPAP. And then by the 3-month mark, when the person hates it, they're never going to try anything again. They don't care that you tell them about bilevel or auto bilevel. They're going to come back a year later, 2 years later. That's how bad this problem is. So that is why looking for every conservative step you can that moves them in the right direction empowers these people. I've been so surprised just in the last year working with individuals using these nasal dilators. I know people that use the nasal dilator and a nasal strip. And these are people, I've got one patient who's got significant heart problems and had a stroke, and he hates PAP. And he's been using this therapy now for a year. I keep telling him he's got to get back on his PAP machine, but he is at least happy, sleeping mostly through the night, and getting clear-cut benefit. Anything you can do to move the person in that direction. There's another new electronic device out, like a dental device. You put it in your mouth. It's called Excite OSA. You put it in your mouth. It stimulates the tongue for about 20 minutes a day. And 6 weeks later, allegedly, it reduces the AHI by 50%. So many things are going to be coming down the pike to be able to help people. Some, obviously, you have to pay for out of pocket. Some people do need surgeries. People still have enlarged tonsils, swollen turbinates. There's a lot of different pathways. The saddest thing in the world is for somebody to get into that pathway of CPAP. They're not psychologically ready for it. They reject it quickly, and now they throw up their hands in frustration and can't imagine there's any help for them. Hopefully, you'll have centers evolving because of what's happened on October 7th and recognizing what we're talking about here, how important this is going to be. Because if you can get people on PAP therapy earlier instead of later, there's going to be some people that are going to have dramatic changes and reductions in their PTSD. Some people may, in fact, be cured. Some people will discover at least much better sleep and be very thankful for that. But there is no quick answer because there's an administrative burden in trying to solve this problem.
Well, I think the main message that we're getting is how wide and deep can sleep medicine be. And if someone is struggling with sleep medicine, you shouldn't give up and you should find the right professional that can think outside of the very small box in Israel, I think, of
right.
sleep.
Well, as I mentioned to you all before when we first met, let me explain that, over the years, I've had encounters with some of the top psychiatric hospitals in the world and always said to them, you need to put a sleep center in your facility. Finally, the Menninger Clinic in Houston put a sleep center in their facility. The psychiatry residency training program that I'm working on is putting a sleep center in their psychiatry residency training program. You have a very large facility for the group that you're working with. And long term, this is my prediction. It's also my hope. In 5 to 10 years, you won't be able to become a psychiatrist unless you've had 6 months training in sleep. In 5 to 10 years, you won't be able to become a psychologist unless you've had at least 6 months training in sleep. So why not say that a sleep center would be at your facility? You actually want to integrate this exactly like that. That's not the level of interaction you want with your patients on sleep would take 20 or 30 years to disseminate out into the community sleep centers. They're not trained that way. These are often pulmonologists or other types of doctors who are not saying, oh, I can't wait to treat PTSD patients. Or at least this is the way it is in America. In America, the pulmonologist is like, oh, I don't want to see these patients. They're crazy. And the patients come to see them. They go, well, you don't need a sleep study. You just need your pills. Why did you come here? These conversations have been going on for decades. It's tragic. It's sad. And it's going on over and over again in America and in other places. I'm sure some of it is going on in Israel. And the question is, will they expand their services and say, no, we want to treat this early we realize this is a part of the picture. So the answer, honestly, is that sleep centers need to be considered for inclusion into mental health facilities. I think that's going to happen. I don't know how or when, but that is the best solution.
I think this is a terrific bottom line for the 3 talks you gave us, because it's really inspiring how we miss third of the day of our patient. You know, we're talking about everything and we miss this night sleep. We don't give it the deserved respect for all its worth.
Right. Can you imagine you're in clinic and you figure this all out, and then you walk out the door and you walk your patient over to the sleep center and you go, okay, I want my patient seen. I want them tested. And it's I even mentioned to Lior, this is a phenomenal revenue generating prospect. I mean, there's all of this work that somebody who's an administrator should be able to say, gee, that sounds like we want to do that. Like we could actually, not to mention the fact, can you imagine the outcome improvement you would have in your patients to be able to get this sleep treatment so quickly? And that's what I'm trying to do over here in Savannah with the psychiatry residency training program.
That's extremely intriguing, extremely, really, really interesting and promising line of thought. Barry, I want to thank you. It's 10 p.m. here, and we're getting the thank yous in private and more questions that we don't have the time to ask. So
I've got a few more minutes unless you want to stop it. It's up to you. I can go a few more minutes. It's up to you.
I think we should respect, the audience time and end on time.
Okay.
Because we can go on forever. It's
not a problem. And people need to sleep. A couple of plugs. One person asked about my future work. I have a free Substack newsletter. It's called fastasleep.substack.com. So if you sign up for that, it's free, and you'll be seeing that I talk about different trends and things in that. And from time to time, it talks about programs that I'm doing. So that's useful. And of course, my website, BaryKrakowMD.com, and of course, my new book, Life Saving Sleep. It's been fantastic working with you all. And if you decide you want to do a follow-up in a month to do just a big Q&A, I'm more than happy to do that.
Thank you so much. It's been amazing. Thank you so much for doing this and the information you gave us and the tool you gave us. We'll see you in March in Israel, I think, right?
Well, we're hoping, Lior, right?
Yeah, we are on it.
Okay, we'll thank all the audience that joined us tonight and the other 2 nights for this intriguing talks. Good night, everybody, and have a terrific good night and good sleep.
Thank you. Bye.
Welcome. Thank you all.